Today we're going to be going over Advanced Medical Module 3. That's going to be covering psychiatric and behavioral emergencies. It's going to be covering pre-hospital pain management, and finally going to be covering synthetic and herbal drug use and abuse. All right, so let's go ahead and jump right into it, okay? So we're going to get right into it and start with pre-hospital pain management. Some objectives we're going to cover. We're going to explain the nature of pain, its definition, characteristics, types, and sources. We're going to identify methods of assessing pain in children and adults using available assessment tools. We're going to discuss common pre-hospital pharmaceutical and alternative non-pharmaceutical interventions for pain and list indications and contraindications for pain in the pre-hospital environment. So we're going to go ahead and jump off into a case study. I'm just going to read a short little paragraph here. Kind of sets the scene for a call, and we'll just kind of walk through this, okay? This slide right here is just your main key points, but I'm just going to read this off real quick. It's a dreary day in a dreary November afternoon. And as the evening rush hour kicks off, the temperature drops. The roads, which are wet from intermittent rain throughout the day, suddenly ice over. As a paramedic on an ALS crew, you're dispatched along with a rescue company fire engine to an accident on the acceleration ramp of an interstate highway. Dispatch reports that the vehicle struck the concrete guardrail and someone may be trapped inside. When you get on scene, you find a four-door sedan against the guardrail, heavy front-end damage, airbag deployment. You've got a male driver that is trapped in the driver's seat. He's got blood running down his face, and he appears to be conscious. Rescuers, fire department begins stabilizing the vehicle, controlling all fluid hazards, all that good stuff. You put your PPE on, gain access to the patient through a rear window. Your partner positions himself outside the vehicle to get equipment to you to coordinate the rescue operations with patient care needs. This patient's going to be a 35-year-old male, conscious and alert and oriented, answering all questions appropriately. You do note a laceration on the patient's forehead, an obvious deformity of his left leg proximal to the left knee. His lower legs are pinned under the collapsed dashboard. The patient complains of severe pain in his left leg. He denies any loss of consciousness. Reports said he lost control of his vehicle on the slippery ramp and crashed into the barrier at approximately 40 miles per hour. He describes his pain as sharp and severe, 10 out of 10. You quickly apply an appropriately sized cervical collar to his neck and enlist a firefighter to hold manual C-spine from the back seat. Let's see. Go on to our next one here. Skin is going to be pale and diaphoretic. Heart rate, 122 beats a minute. Strong, regular radial pulse. So we've got a good, solid systolic blood pressure, right? Blood pressure is actually 136/80, so it's good. Respirations are at about 24 breaths a minute. Pulse ox is 100% on non-rebreather. We've got no significant medical history and no known drug allergies by this patient. Okay, he denies any history, says he's not allergic to anything. Is describing that pain in 10 out of 10. So, we've got different avenues that we can go down with this being an EMT course. And, we're going to be talking about paramedic and advanced level courses as well in this. We can go through all the treatments. That way we know exactly what to expect, especially if you are the EMT and you've got an ALS or paramedic partner, you know exactly what they're, going to be asking for, going to want, going to need. So we're just going to cover the whole base here, right? So what are we going to do? We've got extrication. It's going to take approximately 15 to 20 minutes, right? So we're going to start a large bore IV. We're going to go in the right AC, whatever vein we can get. Start infusing some saline. We have the opportunity right now to, start some fluid administration if we need it. If we saw some vital signs that deem that to be necessary. But if not, we can just infuse at that TKO rate, which means to keep vein open, TKO, right? We're going to administer fentanyl citrate or Sublimase for pain. It's pretty common narcotic that we give for pain management. The common dose is going to be 1 to 1.5 micrograms per kilogram. So we've all heard of fentanyl at this point in time now, with how much of a what it's doing on the street level. We've got a lot of drug dealers and cartels and all kinds of people that are integrating this drug into their street drugs because it's a lot cheaper than what these people are after. And we've got major uptick in overdoses. It is, I can't remember the exact numbers. I want to say it's 100 times stronger than morphine, right? So we do morphine doses in milligrams. We do fentanyl doses in micrograms. So it's such a minute, very, very small dose that these patients are getting that, but that is the pretty much most common narcotic that's given. Ketamine is starting to come around now, and that's gaining a lot of popularity, but we're still mainly talking about fentanyl pretty much wherever you're at. Let's see. We're going to administer that fentanyl imperative to reassess vital signs after administration of fentanyl. So why do we need to do that, right? So we've got any type of narcotic, and we're going to talk about that in the final slideshow that we do, but especially fentanyl being an opiate. It's got some respiratory sedative properties, meaning it can slow your breathing down and stop it at high enough doses, right? That's how these people are overdosing, is they stop breathing, right? So we've got to make sure that we are reassessing all of those vital signs to make sure that, they're breathing, right? First and foremost, but no, make sure that we're not doing any detriments to the patient. Make sure that, respirations are great. We're still oxygenating well. We got a good BP, the whole 9 yards. Make sure that we've got good perfusion signs that way we can give them the best outcome possible. After vital signs are deemed stable, additional doses of fentanyl may be required. We're going to be following local protocol at that point. Depending on where you're at, it's going to depend on how that treatment plan goes. For instance, where I'm at, we will start with fentanyl or morphine, and then once we get you loaded up and we get you packaged, we have IV Tylenol or IV acetaminophen. Man, it works wonders. We use that on every fracture. We've used it on appendicitis, on kidney stones, on gastritis, you name it. We have not found it to not work yet. Now, we may just be getting lucky. It may just be a coincidence, but something about just simple Tylenol in IV form is, great results. So if you guys have never looked into that, might be an interesting little topic, a little rabbit hole to dive down. Let's see. After extrication, mid-shaft femur fracture is noted. So he does have a mid-shaft femur fracture. Is probably why he was rating that pain 10 out of 10. It is a closed fracture, so we went ahead and applied a traction splint per protocol. Patient reported significant decrease in pain. And if you guys have never put a traction splint on someone, or splinted a broken bone for that matter, if you notice when you do splint a broken bone, as soon as you get it stabilized, their pain decreases significantly. Just that unstabilization, just being unstable, those bones not being set where they're supposed to, and just kind of free flowing, wiggling around all they want, it is causing a lot of pain. You got all those nerve endings in there. You've got all kinds of stuff that's just getting aggravated. So if you can stabilize and put it in one spot in that position of comfort, it 100% of the time decreases that pain significantly. If they're awake and alert to tell you about pain, right? All right. So let's get into the meat of it. Introduction. So pain is going to be the most frequent complaint of people seeking emergency medical services. No matter what, right? We could be going to respiratory difficulties, having difficulty breathing. When we get there, they say, yeah, man, it's hurting whenever I take a deep breath, or, hurts when I breathe, period. There's lots of different, excuse me, guys. I'm sorry. There's lots of different avenues that you could go down there, right? Annually, 17.4 million doctor visits are a result of some sort of pain. In 2003, the National Association of EMS Physicians stated that the relief of pain and suffering of patients must be a priority for every emergency service system. All right, and we're going to kind of dive into why. Why does it need to be so important to us that, we put such an emphasis on it, right? So what's the nature of pain? It's going to be the most important physiological protective function. It's defined by the International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So read that definition. When you read it to yourself, a couple things stick out at me that can be gray area for sure is described in terms of such damage. So if you can talk, if you're good with your words, then you can talk somebody into it, right? So it's into agreeing that you are in pain, clinical pain, right? Um, Bad part of our job, I think, is to try to play detective on that, right? I wish there was a cheat sheet for that or something along those lines that we didn't have to rely on our own personal deduction on if this is a seeker or not. Is this legit or is this an addict, right? All right, factors that contribute to experience of pain. So cultural background's got a big thing to do with it. All right, let's talk about that. All right, depending on where you're raised, right? It's just what is social norms, right? And I'm not talking about like, oh, I'm from Texas or you're from Washington. I mean, like these people that are complete different cultures, other countries, right? If you guys are into UFC, for instance, they have a lot of Russian fighters, coming over from Russia and they're competing in the UFC. There was that one guy, he's got a home video. He was like 5 years old. He was wrestling a bear cub. I mean, he was a cub, but like his parents let him wrestle a bear. Like, I have a 5-year-old daughter right now. Not a chance. And like, she's already got her second belt in jiu-jitsu and we're not doing no, but in that culture, it might maybe be a little bit more socially acceptable. They're just tougher, or, there's lots of different factors here. Economic status, what level of comfort are you used to? Is it normal for you to sleep on a concrete slab, with no pillow, no blanket, because if that's not your norm or what you're used to, if you get put into that economic status or that way of life or that scenario, you're probably going to have a little bit of pain, right? I mean, that's kind of, yeah. I mean, it's pretty obvious there. Physical environment, that kind of ties into that as well. Social position, demographic area. It's pretty self-explanatory about your demographic area. What's the weather like? Is it harsh winters? Are they, do you have, there's so many factors. Do you live in Chicago where, there's not very much sunshine in the winter, and so you have a lot of seasonal depression? Or, what is the case here? Physical environment, I said that already. Patient's personal history and situation leading to painful event, and patient's overall psychological state. These are all real fluid, all really person to person, right? We can't really say that, my personal history is totally different than your personal history, especially in relation to pain. I've broken a finger and a rib, but that's about as much as I've broken a bone before. So like, I feel like someone that's already broken an ankle or something like that, and if they do it again, like their experience of that pain would be vastly different than mine, right? And that's just what it is. I mean, there's no way around that whatsoever. All right, physiology of pain. So, sensation of pain is caused by electrochemical nerve impulses delivered from sensory receptors called nociceptors. The receptors have a higher threshold for activation than the rest of the system. The increased stimulation increases the impulses, resulting in an increased feeling of pain. All right, so you can talk about how these thresholds are also person to person, right? So, for instance, women, way, way higher pain tolerance than men do. That's how it is. That's science, is biology. That's how it is. I'm sure has something to do with they were the ones that birthed children, right? So it's probably among the most painful things I feel like that is possible out there, and that's what they're supposed to do, right? So you've got their threshold is inherently going to be higher than ours. I mean, why do you think men have man flu, right? We don't really do very well with illness or injury or pain in general. I know I get all cranky. My wife she hates it. So, Also, they are conditioned. You can condition these, right? For instance, you've got somebody that just picked up weightlifting. Okay. So, they do their full workout. Well, most gyms nowadays have a sauna in them, right? So you can go sit in the sauna, which, if you never jumped down that rabbit hole, lots of studies out there for how beneficial that is to you in the long term, right? So, but you've got a sauna in there, all right? So you go in first day of your membership, you may be able to sit in that 170-degree sauna for 5 minutes, 10 minutes max, that threshold's really not that great. I mean, it's kind of basic, right? You keep going, you go 3 or 4 times a week, and every single time you go to the gym, you go sit in the sauna after your workout, right? Well, eventually you're going to condition that threshold to where you are sitting in there for 25, 30 minutes, 35 minutes, to where you have extended that time. You are quadrupling what you did the first day without even sweating yet, right? So those thresholds can absolutely be conditioned as well. Yeah, I think that's pretty much it for that. You've got that table over there that kind of shows you the different receptors there and what they kind of look like, and what they can sense, right? All right, so we've got 3 different types of pain. Okay, so we've got somatic pain, which is activated by receptors in the body surface or musculoskeletal tissues. Common in surgical incisions and traumatic injuries to limbs. It typically increases with activity and is relieved with rest. So it's like a surgical incision, right? Let's talk about that. I got my appendix taken out. Okay, it's pretty much a laparoscopical procedure now, right? Not very much of a incision as far as how they can access it. But nonetheless, you get out of the hospital and they tell you like, hey man, don't lift nothing and, kind of take it easy for a week or 2. Right. Not to mention, because of all the internal healing that needs to happen, but, you've got surgical incisions, you've got stitches, you've got whatever the case may be, however they closed it. And, the only way that you're going to let that heal is by decreased activity or by rest. Okay. Now we got visceral pain. It's activated by receptors in the body's organs that are enclosed within a cavity, commonly found in chest pain and abdomen pain. Often seen in patients who are experiencing inflammation, infection, or irritation of internal organs. So, your appendicitis, that's a perfect example of that's a visceral pain. Okay. Then neuropathic pain. Malfunctioning of the peripheral nerves or spinal cord. Patients will complain of a burning or tingling or shooting pain, comes in waves and is intermittent in frequency. I feel like that's the last one that I would want, right? Because you don't know when it's going to happen, and it's so hard to figure out how to fix it. You know what I mean? So I think that'd be the last one that I'd choose if I was going to choose one. All right. Acute versus chronic pain. All right, what's the difference here? What makes one different from another? So acute, it starts suddenly. It just happened. All right. I walked into the garage and I hit my head on the cabinet, the toolbox, whatever. And it hurts right now. Okay. That's an acute pain. It starts suddenly and will often have an identifiable cause. You know why you're hurting, you know what you did, and it hurts now. Pain may last a little while or until the wound heals. This all depends on what's hurting, right? Some conditions, such as migraine headaches, can cause acute recurrent pain. All right. So if you look at, what is the definition of that acute pain? Start suddenly, identifiable cause. So migraine would absolutely start suddenly and more often than not has some sort of identifiable cause, right? Whereas it is also chronic, but just meaning in frequency, right? And then we've got chronic pain. May not be associated with an injury and may last for months or even years after the wound is healed. Frequently associated with neuropathic conditions such as fibromyalgia. All right, musculoskeletal pain. Traumatic injuries occur when the body's tissues are exposed to forces with greater energy than they can absorb. Trauma's got two different categories. Okay, so you've got blunt trauma and penetrating trauma. We all probably know what the difference is between those two, but let's cover just in case. Blunt trauma is the result of falls, motor vehicle collisions, anything like that. It's when forces impact the body, but the tissues are not penetrated by a foreign object. So there is no breaking the skin, none of that. All right. It is all exterior, stays exterior. That's blunt trauma. Okay. Penetrating is exactly what that says. It was when the body is pierced by any type of foreign object. And that would be your penetrating traumas. Okay. Whether that be a pencil, a stick, a knife, a gun. It doesn't, if there's something that penetrates, something that gets into your skin, then that is a penetrating trauma, right? Then we've got burns. This is going to exposing the tissue to heat can cause pain. In full thickness, a burn may only feel numbness to the area due to the damaged nerve ends. It's kind of like a ripple effect or a reverse ripple effect, if you will. That's a better word for it. So you've got right where that 3rd degree burn is, or that full thickness burn, there's no nerve endings there. They're destroyed, they're melted, they're gone, right? Whereas as you get further from that site, you get further from that actual full thickness part of that burn, you start to get into your partial thickness or your superficial, right? To where that hurts, okay? Because those nerve endings are still there. So they're able to still associate that pain to this burn. And so at the center where that flame was might not hurt, but 6 inches away from it might be excruciatingly in pain, right? So definitely something to think about there. All right, so burns. Superficial burn. It's going to be a painful reddened skin at the site of a burn. Will not leave a permanent, will not have permanent tissue damage. Sorry about that, guys. Sun exposure is a common cause of superficial burns. So your sunburn, right? Whenever your mom's told you to put sunscreen on, yeah. And then everything hurts in the shower later that day because it feels like hot lava. Pain localized at the site of the burn. Problem with these are, have you ever had sunburn so bad that you got a fever? That is absolutely a thing, guys. You can be out there at the beach or whatnot and, not putting sunscreen on, fall asleep for 2 hours or whatever, get your little beach nap. And then when you wake up, you got a fever because you are cooked, right? And it's almost like a flu. It feels awful. Partial thickness burn involves damage to the tissues of the epidermis. Blistering and redness will be present at the site of the burn, and scalding water is a common cause of this. Full thickness burn involves the destruction of tissues down to the subcutaneous layer. May have leathery or charred flesh and cannot heal on its own, requires a skin graft. Often has a superficial and partial thickness burn around the edge of the site, which causes significant pain. Okay? This one, and I kind of covered that already, talked about why that is. Cardiothoracic pain. It's going to be the next one we talk about. All right, so the chest pain is the most common complaint of people who request EMS, right? I would have to agree. I have to say difficulty breathing and chest pain is one or two and interchangeable, depending on the day. Treated very aggressively. It's geared to relieve pain with the use of oxygen, aspirin, nitroglycerin, and morphine, often related to the decreased perfusion of the heart muscle. So when we can reperfuse that heart muscle or get that perfusion back where it's supposed to be, the pain subsides. Pain also may be from pericarditis, which is an inflammation of the pericardium. They may also experience pain from blunt thoracic trauma, which would be what we call a cardiac tamponade. It's the buildup of blood within the pericardium. Bonus points if you know what treatment it is to take care of a cardiac tamponade. All right, pulmonary chest pain. Exacerbation of asthma and COPD will often cause chest pain. All right, and this is absolutely true. How many times did we run on those CHF patients or those COPD patients, and every time they breathe, they report that it hurts, right? Hurts every single time I breathe. It's described as tightness and swelling within the lower airways and decreased oxygen exchanged within the alveoli. The pain is relieved with oxygen and bronchodilators. As soon as you can dilate them and open them back up, open those bronchioles, I'm sorry, guys. I apologize. I get all that on my system. Open those bronchioles back how they're supposed to be. You can start getting more oxygen into the system, and that starts to make the patient feel better. Pulmonary embolism causes a sharp, reproducible with movement and deep breathing pain. All right, abdominal pain. We've got a bunch of different possibilities for what they could be, right? I didn't go into every single one that they've got listed here, but but I listed some key ones that we're going to see pretty frequently, and we're going to cover those. Okay, so gastritis. It's going to be an inflammatory disease of the stomach that causes burning pain in the epigastric region. Commonly complains of bilateral upper quadrant pain, so both upper quadrants, right? Heartburn, abdominal bloating, nausea, and vomiting are all symptoms of this. And you've got pancreatitis. It's the inflammation of the pancreas, will result in severe epigastric pain radiating to the back. It's often increased when lying supine. Gallbladder pain has two primary causes. You've got cholelithiasis. Wait, no. Cholelithiasis. Yep, that's it. Scrabble word. Gallstones, and then cholecystitis is the inflammation of the gallbladder. So cholelithiasis are the stones, right? And a lot of times, if you get stones, they will get into there's a bunch of different ducts that go into and from the gallbladder that attach to the pancreas and things like that. You've got a pancreatic duct that goes in between your gallbladder and your pancreas. Okay. A lot of times in your elderly patients specifically, and the ones that are just not as physically active anymore, you get gallstones that get up into the pancreatic duct and get stuck there if it's a big enough stone, right? They get stuck there and then they end up perforating. And these people almost die from gallstones. Okay. I mean, they end up on pressers. They ended up on, they're full meal deal in the ICU, ventilator, all that. So definitely, your gallstones are not to be played with, but more often than not, it's very fixable, right? And then whereas that cholecystitis is the inflammation of the gallbladder. Okay. So not necessarily, you don't have to have stones at that point. You just, your gallbladder is irritated and it's inflamed, right? This happens in different people for different reasons. And sometimes it's, you've ate the same thing your whole life, but tomorrow, whenever you go get, baby back ribs or pork or red meat, whatever the case may be, that one food that you've ate forever that you probably love will trigger or make your gallbladder mad, and then it gets inflamed and it's very painful, right? They say that most of your people that have their gallbladder removed, and it's not really across the board of like what food caused the original issue of the gallbladder, but there is one food that is no longer on the table after you get your gallbladder removed because you just simply cannot process or eat it anymore. And for each person, it's different, right? So that's something to look forward to if you have any gallbladder issues. Both produce pain in the right upper quadrant, going to the right scapular region, okay? So it's traveling up to the shoulder. Additional abdominal pain causes appendicitis. It's an infection of the appendix. Causes pain in the right lower quadrant with rebound tenderness upon palpation, often accompanied with fever, nausea, vomiting, and diarrhea or constipation. One thing that you like to do here is come up with a couple different ways that you can assess for this rebound tenderness, okay? Whether that be something creative as, you walk into the hospital room, if you're in a clinic or whatever, you walk in, or you're on scene on a call. You walk into the patient's room, he's a 6-year-old boy, and he's laying on his bed. What I would probably try to do is say like, hey man, come here real quick. And, try to get him excited and see how he gets up off of his bed. Okay. If he's like, like real slow, oh, this hurts. I got to be careful. He's 6. Okay. So that ain't right, or, if they're at, they're at the hospital, you're at the hospital or wherever you're at. And they say, man, my stomach hurts. Bump into that stretcher, bump into their foot on accident. You know what I mean? I hit that foot, nudge that foot with your hip as you walk by the bottom of the foot. And, if they wince, if they scream at you, looks like we've got some rebound tenderness there. Right? Okay, now when I say bump, I'm not meaning shoulder check the foot and, dislocate the person's knee, right? Just tap it, right? As you walk by nonchalantly, don't tell the patient like, hey, I'm going to tap your foot real quick. Tell me if that hurts. Okay, especially your kiddos. You got to be a little sneaky every once in a while when they're not expecting it, when they can't guard it, then hit the foot real quick. And then when they scream, say, oh, okay, there it is. All right, we're good. We got it. Diverticulitis. When diverticula become inflamed, it causes general pain that eventually increases in the left lower quadrant. Pain could be caused by the inflammation of the colon. A lot of times this will mimic the next one that we're going to talk about, okay? You can't discern the difference between the two pre-hospital. It's just they've ran their labs and their studies, and they've been able to isolate what it is we're dealing with at this point once we get to the hospital. But kidney stones. These are going to be, I hate that they say this, calcium-rich crystals that cause pain when moved to the ureters. So, for instance, I have kidney stones, right? I mean, my dad, my uncles, me, my whole family suffers from kidney stones. They're not calcium. Mine aren't. Mine are protein deposits. If I up my protein, if I do something silly like an Atkins diet or low carb or keto or whatever you guys call it these days, if I do that and I increase my protein intake, then here comes a kidney stone. Everybody's different. I've met a guy one time that when he ate a lot of leafy greens, a lot of leafy vegetables, kidney stone. So it can be any type of mineral, natural compound that, that is accumulated in your body that can cause that stone, right? More often than not, yes, it is calcium. But for my case, it's not, right? Calcium-rich crystals that cause pain when moved in the ureters. Sharp, crampy unilateral pain in the flank, often radiating to the lower abdominal quadrants. If you guys have never had a kidney stone before, there is absolutely zero position of comfort. It doesn't matter what you could do. You can put me in a human pretzel, legs above my head, spin me around upside down. I don't care what you do. I'm hurting whenever I'm having that kidney stone, right? I have not found the position of comfort yet to be able to alleviate that. Then your triple A's. Boy, abdominal aortic aneurysm. This is an aneurysm in a blood vessel in the abdomen causing a tearing pain. And if they report this, rut-row, because all the blood from the heart goes out through the aorta, right? Every single bit of it. So if there is a tear there or an aneurysm in that, can you see where I'm headed with this? So definitely you don't want to have somebody tell you have tearing pain, right? That's not good. All right. Abdominal pain in pregnant women. So talking about more along the lines of ectopic pregnancy. So when a fertilized egg implants itself outside of the uterus, usually in one of the fallopian tubes, if growing embryo causes the fallopian tube to rupture, significant hemorrhage or hemorrhagic shock is possible. This can present like acute appendicitis or ruptured ovarian cyst. The only way we can determine what is what at that point is ultrasound and lab testing. That's the only way that we can make an actual diagnosis on that. 95% of patients who experience ectopic pregnancy complain of moderate to severe abdominal pain. Eek. All right, headaches. Man, this is how often do we have to run this one, right? So subarachnoid hemorrhage, bleeding within the brain tissue caused by vessel leakage, causes sudden onset of the worst headache ever. Then you got hypertensive encephalopathy. This is edema caused by fluid in the brain causing increased pressure in the cranium. Patients will present with significant hypertension. So I once was presented with a 15-year-old patient that was presenting like a drug overdose. About every 30 seconds or so, he'd sit up from his bed, exorcist scream. I'm talking the worst, god-awful thing you've ever heard in your life, and then slam back down on the stretcher. And he'd go down there for about 30, 45 seconds. He'd sit back up and he'd scream bloody murder again. He did that all night, right? Parents called the next day. They are wondering what's going on with this kid, right? It ended up being encephalitis, right? And caused by meningitis. All right. We thought it was drug overdose. We thought teenage kid, he got a hold of something. He's screaming, very altered, unresponsive. We couldn't find any vital sign craziness, right? So we ended up just trying to sedate this kid, but it was next to impossible. And pretty much we just wrestled this kid all the way into the hospital and until we figured out what was going on, right? And then we subsequently get blessed with a round of Cipro, right? Because the patient had meningitis. So that's always lovely. But yeah, it ended up, and that's the only time I'd ever seen that. And, whenever we look at that, we were like, man, and, our medical director was like, you wouldn't have been able to call that. We can't see that pre-hospital. That takes some imaging to recognize that. But yeah, it was a doozy for sure. And then meningitis, viral or bacterial infection of the meninges. This causes pain and a stiff neck and fever. All right, so your pain assessment. Not all pain is associated with elevated heart rate, blood pressure, or elevated respiratory rate. You don't have to have that in order to, for instance, be in pain. We've got so many drugs out there that 100% control the rate of your heart rate, right? That controls the heart rate. There's machines that are implanted in people that control the heart rate, right? So sometimes we cannot base our pain assessment off of, it's pulse 76. He can't be in pain. Well, his pulse is 76 because that's what it always is. It's never going to be anything different until it's zero, So blood pressure, elevated respiratory rate. I get it, guys. I mean, that's kind of what we were taught too. But all the new studies are showing that we can't really rely on just that. We've got to take in the whole picture with these patients. A numeric rating scale, or the NRS, and verbal rating scale, VRS. You've got the NRS is a patient number on number the pain on a 0 to 10 scale, 0 being no pain, 10 being the worst pain ever. And then VRS, patient describes the pain with adjectives such as none, slight, moderate, severe, or agonizing. I was like, when you get the patients that are like women, they're like, 10 out of 10. It's like, dang, this hurts as bad as whenever you had a baby. And they're like, okay, maybe a 6. Maybe a 6. But I think pain is relevant to right now, right? I mean, whenever they were in labor, they didn't think that this was a 10 out of 10 pain. But right now, this is 10 out of 10. It might not have been 10 out of 10 6 weeks ago, but right now, I mean, this is awful. This is currently the worst pain that I've ever no, but it's very case by case right there, right? All right, what about pain? So we've got numerous studies. They've shown that patient self-reporting is the most reliable indicator for the existence of pain. What's the problem with this? What is the problem with strictly just relying on homie said he was hurting? What more you want? He came to me, he said he was hurting, right? That's it. That's all I need. What's the problem with that? Why can't we do that? We can not only rely on vital sign assessment or external pain expressions. We must take in the entire picture as well as what the patient reports and choose an appropriate treatment pathway that is best for the patient. All right. So jumping into some non-pharmaceutical treatments. Providing compassion and comforting words has proven to assist in the relief from fear and anxiety that compound distress of a painful injury. We want to treat all fractures with splinting immobilization and application of ice packs, and position the patient in a position of comfort that can assist to the relief of pain as well. Let's see, does it get into this? Let me check this real quick. Right. So you think about how the body works, right? We only got so much energy. We can agree there that the body's got a certain amount of energy. dependent on different variables, right? So you have a big injury, something that's causing pain. If it is still hurting, what is the only thing that you're thinking about, right? So you stabbed a steak knife through your hand on accident last night, right? And you have not gotten treated yet, and all you could think about is, how do I make it stop hurting? How do I make it stop hurting? How do I make it stop hurting? It's hurting, it's hurting, it's hurting, right? Your body's using all of its energy to fix the pain. Whereas if we could fix the pain, it could use that same energy to heal. You get where I'm coming from there? If we only got so much in the tank, why waste it on something that we can alleviate? You see, if we can take care of that pain, then they can use that energy that is being expended on figuring out how to stop pain, because we don't want it to stop. We want that pain to be there so that we have something to talk about, right? Or we have a reason to be. No, we want to stop that. We want to make sure that we can get that pain taken care of. We can heal this patient. They can start on the road to recovery, right? If all they're thinking about is, man, this hurts, I got to make it stop, the body's not using its energy that it should be on things that it should. It's expending all its energy on things that we can handle. Okay. So if we can fix that, if we can get them out of pain, we just boost their recovery time. Yeah, that's it on that. All right. So some common pharmaceutical pain relief drugs that we've got. We've got morphine sulfate. This is going to be a narcotic analgesic. It's a CNS depressant, meaning that it could, suppress your respiratory drive. Fentanyl is a synthetic opioid, 100 times more potent than morphine. All right, so I was right. Peak effect of 90 seconds, but it also has a shorter half-life. And you think about, we're using a micro dose versus what we would be using for morphine, right? Then we got ketorolac or Toradol. This is non-narcotic NSAID. Onset of 10 minutes, peak in 1 to 2 hours, and duration of 2 to 6 hours. Is it Toradol or Tramadol? I think one of those two. And you guys, that are watching this, go ahead and you can cross-reference me on that. I want to say that one of those two are insanely similar and compounds as to heroin. They give this, non-narcotic, and I think it's Tramadol. I think it is Tramadol. I'm starting to talk about it. They give Tramadol out pretty frequently because it's not a narcotic. It's a non-narcotic pain med, right? Well, if you look at like the chemical makeup of it versus the chemical makeup of heroin, street heroin, it is it's strikingly similar. Which kind of would, you hear about those, the mood swings with Tramadol or with extended use of it, or that's the drug that kind of got them onto the opiates, right? So it's a dangerous one. You just got to be careful there. And then ketamine, new to EMS usage and growing in popularity. It's one of my favorites to use for pain management, only because half of what we're dealing with pain is the anxiety accompanied with the pain, right? So we need to take care of the pain, the analgesic part of it, but we also need to sedate. And I mean that lightly. Like, we need to make sure that we're not anxious. Okay. And ketamine's got both properties. It's new to EMS usage, does not have the respiratory depression like narcotics. So it's a little bit more safe. The only thing about it is it is a psychedelic, straight up and down, right? So I love using ketamine in children. Okay. And, you think about why. Well, children have not been done wrong yet most of the time, right? They don't have a bad attitude about the world, about people, about the scenario they're in, the situation they're in. They're usually still pretty happy-go-lucky. The world's a great place. Everybody's nice. That great attitude. Mentally, they're positive, right? You see where I'm going here? So if you have a bad day, like if I have to pick you up on the side of the road because you wrecked your car, and then earlier that morning your dog died, your wife left you, whatever happened, right? And you're having an awful day. Your attitude is in the dump. right? I mean, just terrible attitude. And I hit you with some ketamine, we both got to hold on. Okay. Because here, bad trip city is coming, right? I mean, I'm kickstarting you on something that you'll never want to do again because mentally where you're at, and it's going to feed off of that, right? It's just like all your street drug psychedelics, right? It's, you've run those calls of people that are on bad trips, right? They ate a handful of mushrooms or whatever, and now they're freaking out. They probably had a bad day. If that person would have had a good attitude, oh man, life's great. And then, those are the videos you see of, the people that are just like, oh, look, the clouds are lovely. That's those guys, right? It's all about where they're at mentally. So that's one thing that I've noticed, me personally, with my patients and ketamine, is I kind of try to base it off of where they're at, and then that's going to determine how much I give, right? Because there's also some buffers there. If I think you're going to have a bad trip, then I'll just give you a whole bunch, right? And then you're not really worried about a good or bad trip. You're not worried about anything, So, but you kind of got to base it off of that, right? Like you gotta know, and you don't want to show up to a patient and be like, so how's your attitude been today? Are we in a good mood? And they're like, well, I had to call 911. So what does that tell you? All right. So just definitely something to think about there. All right. Indications and contraindications. Pain is associated with increased anxiety, has a negative impact on immune function and wound healing. It's kind of like what I was talking about. We've got paramedics have standing orders for pain medications. I'm sorry. Paramedics that have standing orders for pain medication tend to administer them more efficiently. Some absolute contraindications: hemodynamically unstable, respiratory depression, altered mental status, labor or pregnancy, and previous allergic reaction to medication. All right. So conclusion for this first one. This patient's pain is relative to the patient and does not always increase vital signs. Management of pain in early pre-hospital setting is beneficial to the patient's immune system and overall healing process. And pain management relieves anxiety and emotional damage that can result from an injury. All right. That's all for that one there. Cool. We will move right along to the next one, which is going to be our psychiatric and behavioral emergencies. All right. So I've got a case study for this too, but let's hit some objectives real quick. This one, we are going to describe the indications, assessment, and treatment of common psychiatric and behavioral patients. We're going to find common terms associated with psychiatric and behavioral patients. And we're going to discuss pre-hospital safety considerations when assessing and treating behavioral and psychiatric patients. All right, so for the case study, I'll just go ahead and jump into it. Medic 26 dispatched to a downtown intersection to assist police officers on scene with a patient who was acting erratically. We arrived to find 6 officers in a dark alleyway surrounding a male who appeared to be in his 30s. It was the middle of February, and the ambient temperature was just above freezing, but the male was wearing nothing but a pair of filthy, once white briefs. Yuck. As my partner and I walked up, we could see that the male was sweating profusely, breathing rapidly, and screaming incoherently at the officers. 2 officers had drawn their tasers, while the others had their asp batons out, but they were preparing to forcibly subdue the patient. A group of bystanders was nearby watching. Many had their cell phones out and appeared to be recording video as the situation unfolded. One of the officers stated that they were called to the scene because the male was running up and down the street, jumping on cars, and had smashed the front window of a nearby business. Dang, he's wreaking havoc, huh? He said that he and the other officers attempted to speak with the male, but had not been able to get any information from him. In the meantime, the male started to beat his head against a brick wall. Each blow landed with a dull thud, and he did not seem to be experiencing any pain, even as bright red blood trickled down his forehead. From my vantage point, 4 feet away, the Patient appeared to have a patent airway, was breathing adequately, had effective perfusion, and there was no visible indication of serious hemorrhage. I attempted to communicate with the male verbally, and he did not respond. After that, I approached the patient, but as soon as I got close to him, he lashed out and attempted to strike me with a closed fist while snarling like a wild animal. It was immediately apparent that the routine assessment and care were not going to be possible. All right. So, pretty crazy, case here, right? But not out of the ordinary. This is absolutely something I ran this. We weren't in an alley, but I ran this pretty much exact call, but just on a back country county road in West Texas, 2 months ago, right? So, ended up being a schizophrenic patient off his medication and recently picked up a cocaine habit. Yeah, it was a wild one for sure. And we'll kind of get into that a little bit more as we go along. But yeah, when you go towards the patient, lashes out, tries to hit you, and snarls like a wild animal. Okay. So what now? What are our options? Not my problem. Okay. Retreat with your partner. We're going to go back to the ambulance until law enforcement can do their job. All right. They can get a handle on the situation, make the scene safe for us, and then we can go come back in and do what we need to do. Patient ends up becoming more agitated, and eventually officers are gonna deploy the taser. This infuriates the patient more, and he attacks officers. He just rips the barbs out and just keeps on fighting, right? One officer sustains a bloody nose, and one officer actually breaks his arm. Okay, so maybe not the best choice. Patient is finally restrained face down with officers on each limb. As you treat the injured officers, the officers restraining the patient begin to yell for help. You find that the patient is not breathing and has no pulse now. Resuscitation efforts are unsuccessful. Due to bystanders' video obtained by the patient's family, a lawsuit has now ensued. The results of the litigation are still pending after your court case. Okay? Or we've got option two. So when a patient appears to be experiencing excited delirium, which is going to be a life-threatening medical emergency. It is clinically a life-threatening emergency at this point. Patient was evaluated and deemed to be an immediate danger to himself and others. And local protocols call for chemical sedation at this point, right? We coordinated with the officers to perform a safe physical restraint only as a bridge to administer the chemical. Ketamine was administered. The patient was sedated and placed on the cot in a supine position. No officers were injured, and IV was established for further drug administration if needed. Okay? What do you think is going to be the safer option here? All right. Before you jump in and say two, right? Yeah, two is in this scenario is the better option, right? But this is going to be protocol based too. Okay. All right. This is going to be how is your system? Okay. If your system is one of those and you are in a dangerous area that says get out until the people with guns get there, then do that. Okay. A police officer might just have to break an arm. I don't know what to tell you. No, that's bad. But you've got to weigh your options and know what you've got there, know who's there, know your personnel as far as, your protection, your law enforcement agency, and make an informed, educated decision on that, right? But my guess is option two for this, by the way, for the record. All right, so introduction. Psychiatric and behavioral emergencies are a result of three different causes. All right, you've got organic or physical, functional or psychological, or chemical, drug or alcohol. All three alter a patient's mental status in the same manner. All right. And it's just going to take a, detective or, some type of investigative work to determine, it doesn't take a detective, but some type of detective work or investigative work to determine which one of these are causing that psychiatric or behavioral emergency. Okay. Depression. 10 to 15% of the population has one form or another. It's common psychiatric and behavioral emergency. Sorry about that. All right. So your mild depression normally lasts a day or two. You've got some changes in appetite, fatigue, possible increase or drug and alcohol consumption, just, kind of trying to cope, feeling of sadness and lack of self-worth. Moderate. It's going to be less than 2 weeks. Same as mild, but with impaired ability to concentrate. Body feels like it drags, constipated, loss of interest in enjoyable activities, and reduced interest in sex. Major, longer than 2 weeks, dramatic changes in weight, loss of memory, sleep disturbances, overwhelming feeling of sadness, agitation or irritability, feeling of no future, and suicidal thoughts. I think that 10 to 15% probably is pre-COVID. What do you guys think? Would you venture out to say that? You know, our depression rate skyrocketed once nobody could leave their house. All right, seasonal affective disorder and bipolar. Seasonal affective disorder varies in length and normally occurs during the winter months. I didn't even know this was a thing. I had no idea that this existed. You know, I was born and raised in Texas, right? It's not that cold. I mean, it gets cold, but it's not awful. You know, my little brother plays college baseball. You might actually see him playing in the majors one of these days, but he plays in Chicago for a Division I school up there. He pitches, right? And my sister plays volleyball in Chicago, right outside of Chicago. She's at a different college than him, but they're both like about an hour and a half away from each other, right? My sister came home and kind of told us about this. She was like, didn't really know what it was. It was like, man, I'm kind of feeling off, blah, 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 blah. And turns out she had seasonal depression, right? It is so cold and dreary and rainy and snowy and there's no sunshine. And she said like that, it takes a toll. And, I never even thought about that realm of possibility, right? And then, she comes home and tells us that, and it's like, wow, like I gotta get it. I gotta travel because this is crazy, right? I never even thought that could happen. But yeah, so it's very much a thing. Bipolar varies in length, dependent of internal and external factors. Normally follows the course of a balanced mood until the patient is affected by one of the factors, then moves to a hypomania state. Patient experiences different levels of behavior. You've got mania, balanced, and depression. Suicide. There are 10 to 20 million attempted suicides per year, and nearly 1 million of these are successful. While most people are depressed, may not be suicidal, most patients that are suicidal are depressed. Not really that confusing. Just because you're depressed doesn't mean that you're going to kill yourself, right? Or that you're suicidal. But most people that are suicidal are depressed. Okay, so the geriatric population accounts for nearly 20% of all suicides, while accounting for only 12% of the population. Okay, pretty high rate of suicide in the elderly or the geriatric population, for sure. All right, indications of suicidal thoughts: increased self-isolation, guilt or the inability to forgive oneself, hopelessness, anxiety, sleep problems, increased alcohol or drug use, taking an unnecessary risk, destructive behavior, self-destructive behavior, dramatic decrease in productivity, and dramatic recent increase use of sick time. Some indications of imminent suicidal behavior. So that's going to be, some indications for your thoughts, but this is going to be imminent of actual suicidal behavior. Like they're on the watch, right? Talk about death or being dead, sudden purchase of life insurance policy, threatening or expressing a wish to be dead, making a suicide plan, giving away prized or important possessions, withdrawal, sudden purchase of firearms or other weapons, desperation, stockpiling of positions or of poisons or medications, writing a suicidal note, and sudden dramatic improvement in mood or calmness. Nothing really to dive into there. Those are all kind of self-explanatory on why those would be red flags, right? All right, dementia. It's a group of progressive brain disorders that gradually leads to a person's inability to perform common daily activities. This manifests itself as confusion, forgetfulness, Short-term memory problems, difficulty organizing and expressing thoughts, and change in behavior. We've got two different classifications for dementia. Okay, you've got cortical and subcortical. Your cortical is Alzheimer's, vascular dementia, and dementia with Lewy body. And I'm pretty sure Robin Williams had Lewy body dementia. I think he was in early stages of Lewy body dementia, and that was one of the main contributing factors of his depression and suicide. And then subcortical, hypothyroidism, Parkinson's disease, and dementia due to hypocalcemia. All right, Alzheimer's disease. It's the most prevalent type of dementia seen in geriatric patients. Nearly 10% of people over the age of 65 to half of those over 85 are thought to have Alzheimer's or another form of dementia. The cause of Alzheimer's is undetermined, and there's no cure for the disease currently. There's not really much we can do. This is one of those points that I was talking about in that sauna rabbit hole. They say that if you spend on an average of 20 minutes a day in the sauna after your workouts, 10 to 20 minutes a day in the sauna, that it significantly decreases your chances of getting Alzheimer's at an older age. Don't ask me how they figured this out, what they're using, why they guessed it. I don't know. But it's not for me. I don't want Alzheimer's, so I go sit my butt in that sauna just because, there's other benefits to it too, but, might as well see what happens. Indications of Alzheimer's. Memory loss is the first indication. It's like when your grandma, you get there to your house and they're like, my name's Riley. And, my brother's name's Tyler, sister's name's Samantha, my dad's name's Mark, and I get to my grandma's and she's like, oh, hey, Mark, Mike, Danny, Tyler, says every name, in the book, and then we finally are like, Riley. And it's like, got it, but that's your first indication. Right now we're dealing with this with my wife's grandmother. She has a beach house in South Padre Island here in Texas, and she also lives in Anaheim, California. And Anaheim Hills, like right down the street from Disneyland. We go and visit her several times a year. Our last visit, we went to California, and she yelled at us because we hadn't come to see her in Texas. We just spent a week with her 3 months ago in Texas. But she forgot about that entire trip. It was gone. So, that is a red flag. You can see right there, you're like, whoa, but she's 93 years old, wakes up, drinks Bloody Marys, and then when it's socially acceptable, switches over to scotch and water. And this lady is just sharp as a tack, man. She is sharp as a tack, physically. Now, mentally, we're starting to get some deficits there that are starting to be noticed. But as far as physically, she's, A+. Inability to perform the day-to-day tasks such as reading, writing, or how to drive. Total loss in an experience, recent or past, and total loss in remembering and knowing a person. And I could probably, if you're, not to mention being the person that's got the Alzheimer's, but like those of you that have children, like imagine growing old. How depressing is it? We have possibility of growing old and our kids growing up. We raise our kids, we do everything for our kids. Our kids love us. It's been a great life. We end up getting Alzheimer's when we're old and you forget your kid. That's why I sit in the sauna 20 minutes a day. I don't want to forget my kid. That neither one of them. I don't want to forget my daughter, my son. No, I don't want to forget my kids. So, which I'm sure that is a very far-fetched, idea, but it happens. Like I personally know people that forgotten family members, maybe not children, but they don't know who their wife is when they wake up, and I don't want that. I want to do everything in my power to make sure that don't happen. Right. Common warning signs for Alzheimer's: memory loss, difficulty with language, poor decreased judgment, misplacing items, changes in personality, inability or difficulty to perform familiar tasks. Schizophrenia. It's going to be a mental illness causing significant social and occupational impairment. It consists of disturbed perception or expression of reality. People that suffer from schizophrenia often report auditory hallucinations, paranoid or bizarre delusions, this, I'm sorry, or disorganized thoughts or speech. You've got 5 different subclasses for this, okay? You've got paranoid schizophrenia, disorganized, catatonic, undifferentiated, and residual. The exact cause of schizophrenia is unknown. Okay, but you see they're on lithium. I think there's a couple newer treatments out there, but they take lithium. All right, that's a schizophrenic, right? These people can be dangerous. Okay, they've got no real recognition of the world and how it's going right now. Like, I mean, that patient I told you about went out onto a back county road, called his dad, and said, "Hey, I'm going to overdose. I'm going to take all my pills." So he calls 911. He says, "Hey, my son just called me from this county road, said he's here and that he's trying to kill himself." Right. So, like, we're already like, well, if he really wanted to kill himself, why would he call his dad and tell him exactly where he's at? Right. Like, if he really wanted to kill himself, then he would have just killed himself and made somebody find him. Right. So, red flag. So we get there, kid's in his seat in his car, right, in the driver's seat. Police haven't pulled him out yet. I go to try to talk to him. He says, "I don't want to talk to you." I say, "All right, cool, man. Just tell me your name and I'll get out of your face. Like, and then you can just deal with the cops, right?" And he's like, "I refuse." I said, "Okay, I understand. Like, I'm good with that, brother. Like, I don't, we don't have to do this. And, if you just tell me your name, you are well within your rights. That's fine, blah, blah, blah." When he goes from, he's like right here, leaned back in his chair to lunges at me. And the fight was on. I mean, and police were like 30 yards away, back at their cars while I'm talking to them. Lots of things happened that shouldn't have, right? But ended up, dude had a knife in his hand and it just wasn't opened, right? But it could have been bad. So there's a couple write-ups that ensued on the law enforcement side after that because of how that scene was handled, but that's neither here nor there. But it was absolutely sketchy. It was absolutely one of those that I could have been hurt. What if I would have been a gun in his hands? And they didn't clear that car before they let me walk up to it. He could have blown my brain across that county road. There's there's so many options. There's it could have been bad, right? So yeah, it was ugly. But they don't know why. Why does this happen? But very altering. I mean, they are very, very, very altered. Even on when they're being treated, they still have some days that it's up in the air. Right? These are complex patients for sure. Indications: delusions, auditory hallucinations, uncontrollable anger or aggression, anxiety, disorganized speech and behavior or irrational acts, senseless acts, repetitive speech, aloofness, and disrupted daily activities. All right, so jumping into the assessment of a psychiatric patient. Scene safety is going to be the first part of the assessment due to the psychiatric patients having the potential to be aggressive, okay? I live and learn. I'm not talking to you unless you pull them out of the car. If they're still in their vehicle and you've called me, no. You're going to need to get them out of their car, search them, make sure that they don't have weapons on them before I can make scene. You know why? Because you have a weapon, Mr. Officer. I don't. So, right. So we're going to make sure that our scene is safe. Now, I've lived and learned as far as that goes. If you see signs of aggression, do not enter the scene until it is safe or retreat, then wait for the scene to be made safe before entering once again. And we'll go back to that case study. You can retreat, but that doesn't mean you're saying not my problem. You can back out and recollect, right? You can back out and say, whoa, man, that got heated in there real quick. Let's get a game plan, okay? I'm going to drop the ketamine. You go talk to police officers and tell them, get the student in a headlock. And then as soon as we walk in, shift over, give us an open shot. I'm going to stick them and then we're going to go. Okay. That's an option, right? But we did retreat. We did get out of there because it wasn't safe. And then we made a plan and then we, go in and execute, take care of the patient, right? Perform a general assessment on the patient. You may have to build a rapport before you can physically assess your patient, especially these patients. If they are on some type of psychiatric break, they probably don't want to be touched. You could absolutely set them off by just a simple touch, okay? Head to toe performed and medical assessment can be used to determine the events of the current emergency. Medications. Psychiatric meds are divided into 5 classes. You've got antidepressants that obviously treat depression, can have a deadening effect on all emotions. That's one common thing that you'll see is like, yeah, I used to take antidepressants, but kind of made me not me. I was just kind of like a zombie. I was just there, like I wasn't ever happy. Also wasn't ever sad though, but for instance, my mom, when my grandmother passed away, she had some depression, right? I mean, not really far fetched there, kind of understanding. So she got put on antidepressants for a little bit. It was her friends that ended up telling her like, "Hey, we don't like this," and what it was they had like a girls' night and went and watched some little sobby, sad movie, and she didn't cry. And like my mom cries, like she's a crier, right? And so like whenever you don't have that, and it was like, this ain't you. So that's absolutely a thing. Anti-anxiety. Treat the anxiety disorders like nervousness and general anxiety and sleep disorders. Can be used to relieve stress from other medications. Antipsychotics can be treating psychosis such as schizophrenia and mania. Mood stabilizers can help these symptoms of depression depression in people with bipolar experience. My gosh, I'm sorry about that. That was a tongue twister. Psychostimulants used to treat ADHD and other conditions. When they mean other conditions, a lot of things that's very common now are your weight loss drugs. Like they'll go to the doctor and they'll say, "Hey, I'm just having trouble losing weight." They get put on phentermine. Phenner what? Phentermine, right? Like very like. Did you say methamphetamine? Close. So, and it's it was clinically made as an ADHD drug, but drastically lose weight. You don't want to eat, kind of like methamphetamine. But these patients that really need it is as far as for ADHD, very beneficial. But you've got a whole market for it as a drug law or a weight loss drug as well. Legal issues. Patient has the right to refuse treatment. You want to know the regulations for your local state and federal laws pertaining to mentally ill patients. If a patient is conscious and aware of their surroundings, appear to understand the risk associated with refusal of treatment, and the patient does not appear to be under the influence of illegal drugs or alcohol, they're able to make a sound decision. Most states allow peace officers and mental physicians to detain a mentally ill patient for a period for evaluation and determine if they pose a threat to themselves. I feel like that could be a whole slideshow on its own. The semantics and the specifics and the laws and the regulations and it's definitely state and locally driven, but of your emergency detention orders for that instance and transporting these patients, what you need to do, who should be there, who should accompany you, what we can do as paramedics or EMTs and non-correctional officers or law enforcement officers, aka detaining patients. That's a whole different conversation. Okay. Conclusion for this one is psychiatric and behavioral emergency numbers will continue to grow as our elderly population continues to grow. It's just going to go hand in hand there. Understanding the foundation of a patient's psychiatric disorder will help to ensure better care for the emergency at hand. And then additional resources should be used when the patient shows to be of danger to themselves or to others. All right, that was it. We've got one more, okay? And this one is going to be over the synthetic and herbal drug use and abuse. You guys watch Narcos? Pretty good show. If you haven't, I recommend it. All right, so some objectives we're going to cover. Identify common opiate, synthetic, and herbal drugs of abuse. We're going to discuss pre-hospital treatment of patients under the influence of synthetic or herbal drugs and recognize the common clinical signs and symptoms associated with use of these drugs. One thing you'll notice before we even get into this, in this case or in this article and in this slideshow, when they say herbal drugs, they're meaning like stuff that we don't typically really have here in the continental United States. right? And we'll kind of get into it. But I was surprised whenever I went through this slideshow the first time way back when we were teaching this live. I was like, "It's an herbal drug here, I'd like to think." But all right, case study. You, a paramedic named Bill, and your EMT partner, Lila, are toned at 3 o'clock in the morning for a man acting crazy, okay, and believed to be high on unidentified drugs. The report states he has injured one bystander who had approached him in an effort to help. The bystander then called 911 and police are en route. You arrive on scene to find a man in his mid-20s wearing nothing but his undershorts, yelling and cursing at 4 officers who have him surrounded. Most of his words are incoherent. He does not seem to hear or comprehend what the officers are saying to him. The bystander cannot be located, and an officer says he has left the scene. As you guys park the ambulance, the man freezes. He stares at the new addition to the red and blue flashing lights of the police cars and then throws his head back and screams at the sky. Without warning, after his scream, he rushes one of the officers, who narrowly dodges while catching the patient's arm and attempting to twist it behind him. Others move in, and the four of them attempt to wrestle the man to the ground. He fights them with almost superhuman strength, screaming and cursing the whole time. Keeping a watchful eye on the patient and police officers, you guys quickly prepare to treat the patient once he's subdued. Lila spikes 2 1-liter bags for you of saline. You pull up doses of ketamine and Versed. IV therapy is preferred, but protocol allows for IM ketamine for agitated patients if necessary. The man starts screaming, "Demons, get off me, demons, I'll kill you." Throwing your equipment on the cot, you and Lila approach cautiously. So we've picked option 2 from the last case study, right? That's where we're at. The time on scene is 3 minutes now. Officers are still struggling with the man, trying to take him down and keep him down with little success. One glances in your direction, sees the syringe in your hand, and nods. "Medics here, boys." That's what he calls out to the other officers. The other 3 never even look up. They never skip a beat, but they slightly shift their body positions to allow you access to the fighting man. You're able to quickly jab the syringe into a thigh muscle, plunge the medicine into the struggling patient, and move back as quickly as you can before you get punched yourself. Man screams and lunges upward. The officers hold tight, and all 5 of them fall to the ground. Time on scene is now 5 minutes. The officers are tiring. The patient is not. So you're starting to get a little worried. He lunges forward, dragging all 4 of them with him. IM ketamine takes 2 to 5 minutes to take effect. So they end up just having to wrestle him until he actually gets sedated. Once the medication takes effect, they place the patient on a cot in the supine position, right? Because in option 1 of the last case study, they put him face down and he died, right? So we don't want to do that. We want to restrain them face up to where you can always assess an airway. IV is established for further sedation as needed and transported to the ER for further evaluation. And no telling what kind of drugs he was on, right? All right. Introduction. Drugs of abuse are chemicals taken into the body for non-medicinal reasons with the intent of creating mind and mood-altering changes. These commonly abused drugs: heroin, cocaine, ecstasy, LSD, marijuana, and prescription medications. Addiction. It's a complex and misunderstood chronic brain condition that causes compulsive action to seek out the addicted substance. It's often with harmful consequences to the person who is addicted to those around him. So our brain has got a special set of reward systems for certain things. When we get addicted to something, that pathway reward system is going to be altered or flawed, if you will. Like that drug goes in and alters that pathway system for that dopamine release. Okay. And once the brain figures out, oh, I just got to take this drug, and then if you take this drug, I'll dump my dopamine. And you've got that common understanding with yourself. That's when this addiction starts, right? It is, lots of predispositions to it, but this can be self-inflicted, right? Opiates, drug derived from or related to opium, typically used for the management of pain. You guys watch Ozark? That was good. Speaking of the poppy fields. Heroin, oxycodone, hydrocodone, morphine, fentanyl, methadone. Those are all types of opiates. 1 out of every 3 opioid prescriptions is being abused. I said that right. 1 out of every 3 opioid prescriptions is being abused. Sales of opioid prescriptions in the U.S. nearly quadrupled since '99. Drug overdose deaths in 2015 far outnumbered the deaths from auto accidents or guns. And opioid abuse costs the U.S. economy nearly $79 billion annually. And if you go back to the root cause of this, you can start to talk about these drug companies that are marketing these drugs and the approaches they're taking. You're getting feedback from these doctors that are saying like, hey, man, this is happening. This is happening. All these different side effects are happening. And they're becoming addicted. Oh, they're not addicted. That's just breakthrough pain. So give them more, double the dose, and because for the medicine company, what does that do? Well, that doubles the revenue, right? That doubles our products that are being bought because we're giving twice as much to everyone. So, obviously that's a great business model for them if you're not thinking about what it's doing to humans, but it's all about money here, right? How do opiates work? You're going to bind to the opioid receptor sites in the CNS, peripheral nervous system, and immune system. There are 4 different opioid receptor sites, with the mu and kappa receptor types being the most common, which opioids bind to. Okay, these receptor sites are responsible for pain, thermoregulation, respiration, endocrine and GI functions, mood, and motivation. All right, so pretty important, right? When opioids bind to these receptors, they're going to inhibit that neurotransmission and cause pain relief, euphoria, respiratory depression, decreased GI movement, cough suppression of some hormones released during stress, and pinpoint pupils, a classic narcotic overdose sign. All right. If you've ever had any type of, surgery, like when I had my appendix taken out, which by the way, I had appendicitis and a 8-millimeter kidney stone at the same time, double whammy. So I was in the OR for like 4 hours. But that decreased GI movement from the pain meds that they gave me was real. Man, I almost went back to the hospital just because I was so scared because I was constipated. I was like, man, I can't do this. Right? I was nervous, but obviously we're okay. Right. That was my first surgery. So that was another time my wife was like, you are a baby. It is. All right. Opiate overdose. Oh, wow. Opiate overdose. There it is. Oh, there it is. Yeah. Opioid drugs are the biggest offenders in prescription overdose. Some signs and symptoms. That's a kid in the back seat, isn't it? That's sickening. Shallow breathing, confusion, respiratory failure, small pupils, and unresponsiveness. Well, how are we going to treat this? Opioid antagonists, Narcan or Naxalone. Oxygen, airway protection, monitor their vitals, and blood pressure support. So one big change in Narcan, right, is you only give this if they have that respiratory failure, huh? Or if they got that respiratory suppression. You just give enough to get them breathing again. And it's not like how we were taught. We just wait till they're, slam 5 milligrams of it as we walk into the ER because, they're going to wake up and fight. And we don't want them to wake up now. We just want them to breathe. So that's one big key thing that we've done different. That's evolved, right? Opioid antagonist. So Narcan is a primary opioid antagonist. It causes partial or complete reversal of the opioids by binding to the receptor site and can reverse the respiratory depression caused by that opioid. It's so effective, auto-injectors are being produced for the layperson to administer if needed. Pitiful. This has a half-life that is often less than that of opioids, so repeat dosing may be necessary. In these places that have the absolute just awful problems with the opiates, your really, really big cities, the police officers are carrying boxes of Narcan injectors in their squad cars. And it's like, man, get a punch card, right? They are using them like crazy. And it's sad, man. It really is. Herbal drugs, from plants to hallucinogenic and psychedelic properties. Herbal drugs are spread across the globe, often carried by refugees who consider their use as cultural, common, and less harmful than drinking alcoholic beverages. Most are illegal in the United States. We kind of have steered away from talking, having a lot of slides on marijuana. We really kind of only go into these psychedelics here. A couple of just different herbal stuff that are, from other countries like I said earlier, but we'll get into it. But, with marijuana being on the cusp like it is, and especially having so much medicinal properties now, it's still, federally illegal, but you definitely have to know what it can do, right? You have to know that federally they're behind the eight ball and they're behind the game, and decriminalizing that because of the medicinal properties, because we have seen it medicinally work for certain patients, right? And so therefore, we need to be educated on what possible things we could see, like cannabinoid hyperemesis syndrome and things like that. But we're not quite there yet, especially for some national registry things on a national level. We need to kind of cover all bases for that, right? Some synthetic drugs. Newer synthetic substances of abuse have been dubbed novel or new psychoactive substances. Many are manufactured in China and India, and some are created in home labs under less than sanitary conditions. Mixing different types of chemicals has become the new normal in drug abuse. The effect of these chemicals can have on the brain has been known to make people homicidal, suicidal, and some have died accidentally because they believe the hallucinations in their mind. People with underlying health problems may be especially susceptible to negative side effects of these drugs. When my wife first got out of nursing school, she got a job at one of the prisons here in Texas, and that's where it's the biggest right now. Or for the synthetic drug, your spice and K2 and all, the synthetic marijuana. They love that stuff in prison. I mean, you'll walk in. She says you can go into a pod. We got 50 to 100 inmates, right? And they're all high. Like it looks like just a room of zombies. Like they're all just, because they all smoke spice or K2 or whatever it is. And of course they have a lot of seizures and things like that are, associated with that. But it is a huge deal in the prison system. Drug laws. In 2012, 26 new substances were added to the list of Schedule 1 drugs, including 15 cannabimimetic agents like K2 and spice, like I talked about, and various other phenethylamines, which are found in bath salts. This law banned the chemical used to make salts, isomers, or salts of isomers. Sorry. And cat or cathinylene. All right. This is what I was talking about, your herbal drug that is kind of, not from here. It's an amphetamine-like natural stimulant found in the fresh leaves and shoots of the cat plant grown in East Africa, Southwest Arabian Peninsula, Yemen, Somalia, Ethiopia, and Kenya. To the people of these regions, this is a normal thing. It's considered no more dangerous than coffee or nicotine. I mean, this is an everyday thing there. It's not like they don't look at it. Society does not look at it as a drug. Okay. Long-term use has associated health-related issues such as malnutrition, cardiovascular problems, gastric disorders, chronic and severe hemorrhoid problems, and esophagitis. What they do is they chew on it. Okay, it's these leaves, and they put it, they wad it up, they wad the leaves up, and they put it in their cheek like chewing tobacco, right? And then they just chew on the juice, and they swallow that juice, right? They don't spit that juice out like you would for tobacco. You want tobacco, you spit it out, right? They swallow that, and so that's why you get the gastric disorders, because of them swallowing constantly, right? But it is looked at there as, you have a big decision you need to make. Well, go get some cat ball and put it in your cheek and chew on that for a little bit, and that'll help you, kind of focus on what you need to. That's what it's used for there. Or if you have a headache, we'll go chew on some cat for a little bit, and that's what they use it for. But it does have these, these side effects, and it is absolutely illegal in the United States. So, what are we going to see very much of it? Possibly not, but I guarantee you people have this here, because it is such a staple in some cultures that that's what they grew up doing. They're probably going to try to do that here too, right? So definitely something you got to take into consideration. Bath salts, synthetic cathinone or cathinone. There we go. Made its major appearance as an active ingredient in a deadly substance called bath salts. It's sold as a legal alternative to amphetamines, cocaine, and ecstasy. These chemicals elevate the dopamine levels up to 10 times more than cocaine. Bad trips cause paranoia, hallucinatory delirium, and death. No thanks. Flocka. That's that Florida drug, isn't it? Synthetic cathinone also considered to be more addictive, dangerous, and deadly than its earlier counterparts. It's the worst one. Good. Known as the zombie drug, devil's drug, 5-minute insanity, and gravel. Short-lived euphoria is often followed by severe anxiety, erotic thoughts, paranoia, delusions, mental and physical impairment, dangerous tachycardia, severe hypertension, hyperthermia, and death. Wasn't Flocka what like that guy in Florida that like they caught him like eating another person's face like on the side of the road? Like wasn't he on Flocka? I think that's what that was, wasn't it? No thanks. Pre-hospital treatment. It's symptom driven. Okay. Ensure scene safety before approaching. Your psychotic behavior and superhuman strength are becoming common symptoms of drug abuse. It's very important not to get tunnel vision. Not all bizarre behavior is drug induced. So obtaining a history of current illnesses may be difficult because many drug abusers don't want to admit the drug abuse. Okay? But in reality, that's what's going to be the best help for them, right? Is that they can tell us what's happening. We can fix the symptoms. But if they don't, then we're kind of left in the dark. Dehydration and hyponatremia are common and should be treated for with the use of IV fluids. Your secondary assessment. It's going to be checking for heart rate, skin color, and elasticity, body temperature. Are they diaphoretic? And can they provide, and diaphoresis or not can provide vital information. Sorry. High body temp is common and provides a definite threat to the patient. So passive cooling should be initiated. It's especially going to be the case in your amphetamines, your ecstasy, things like that. Your rave drugs, like those are going to be, your hyperthermia is common in those drugs. Dehydration and hyponatremia are also common and should be treated with fluids. Monitor blood glucose levels throughout the transport. Restraint in transport. Never restrain a patient face down or hog tie restraint. And that's going back from option 1 of the last case study, right? They can stop breathing. If you've got a lot of weight on top of them, if you like dogpile them, they could, you could be inhibiting that chest wall expansion. And so they're not breathing correctly, right? And they'll end up suffocating and dying. These patients may require physical and chemical restraint. If physical restraint is necessary, patients should be restrained in a supine position and should only be used until the chemical restraint can be done. That's going to be protocol driven. Some protocols state that once you win the restraints, they don't get taken off to the hospital. But that's all going to be on where you work and depending on that. Chemical restraint can be accomplished with the use of benzodiazepines or ketamine, depending on your local protocol. Rapid transport of these patients to a local hospital should not be delayed. For your combative patients, this can be a patient suffering from any type of toxic psychosis, or obviously going to be a danger to himself, herself, or others. Okay, we're going to need to understand how different physical restraints can exacerbate already unstable mental physical problems. Okay, you've got to know how to play the game, if you will. Okay, so if you know that they're right on the cusp, and any type of physical altercation, anytime you touch them, you get close to them, you get in their bubble, it sets them off, right? We're probably going to try to refrain as much as possible from, 4-point restraints and, up close and personal, blah, blah, blah. You're not really going to want to do that. Kind of try to play the word game first, but we also have to do a job, and we've got a line that we can't cross there as far as before it gets too dangerous for them, and we've got to do something, right? And then rhabdomyolysis. Or rhabdomyolysis, is a common occurrence. We just call it rhabdo typically, for these patients as well. Just like your elderly patient that fell at 6 p.m. last night and it's 3 p.m. the next day, they've been on the ground the whole time. They probably have rhabdo. They're probably in rhabdo at that point. It's when the body burns enough muscle tissue instead of sugars or fats for fuel. Okay, they haven't been able to eat. They've been on the ground. They've been in a tough spot. They've been straining and struggling and trying to get up. The muscles are going to start breaking down, right, in order to produce some energy for the body. But that's whenever you have like urine the color of sweet tea, real dark. It's pretty profound. All right, conclusion. The use of synthetic drugs and the abuse of these drugs is on the rise. The number of instances EMS providers come in contact with a patient that is under the influence of these will continue to increase. Even after new laws are formed, these chemical drugs are continually being changed and made into new substances. So all they do is they just take one chemical out and put a new one in, and that makes it legal again because they listed this chemical as being illegal. Well, I didn't put that one in there. I put this one. That's a different makeup, and so that's how they're getting away with it currently. But it's just a cat and mouse game is all it is. Okay. All right. So that's pretty much it for what we're going to be covering this module today, guys. I hope you enjoyed it, and we will see you guys next time. All right. You guys take care out there and be safe.